They're coming in. Okay, it looks like people are getting settled. Do we want to begin?
Sounds good. All right, good day, everyone. Welcome to the UIC Global Health Colloquium, which is a lecture series co-sponsored by the Colleges of Medicine, Nursing, Applied Health Sciences, Pharmacy, Dentistry, and Social Work, and the School of Public Health. I am Rohan Jeremiah, Interim Associate Dean for Global Health at UIC College of Nursing. And as we start to talk about or introduce our speaker for today, wanted to set the tone that this year, today is actually World AIDS Day. And this year's theme set by UNAIDS is inequalities and AIDS and pandemics. Before we introduce the speaker, we also want to establish some sort of ground rules or protocols for our talk today. Dr. Farley is going to speak for about 45 minutes. There'll be a 15-minute Q&A session where you'll be able to submit your questions via the Q&A feature on this platform. So it's my great pleasure to welcome Dr. Jason Farley. Dr. Farley is an endowed professor of nursing, innovation, and leadership at the Johns Hopkins University School of Nursing, where he directs the Center for Infectious Disease and Nursing Innovation. He's an infectious disease nursing epidemiologist and nurse practitioner. His clinical activities in the John Bartlett specialty practice spans HIV prevention, treatment, associated infections, namely tuberculosis. Through 2 decades of research, his work seeks to optimize a patient's diagnostic experience with infectious diseases and to improve their linkages and retention in care. He is the PI of a cluster randomized trial designed to tailor nurse care management for persons with drug-resistant tuberculosis and HIV co-infection in South Africa, and a co-investigator on an adaptive SMART trial, which involves an adaptive randomized evaluation of nurse-led HIV treatment and retention interventions for female sex workers living with HIV, also in South Africa. He recently received a Discovery Award from the Johns Hopkins University to conduct a randomized controlled trial to improve the treatment, adherence, and retention in care for patients with TB and HIV co-infections using a combined community health worker armed with digital adherence technology to escalate adherence support in real time. In Baltimore, he developed a community health worker model that offers an unapologetically enabling approach to achieving equitable access, retention, engagement for patients struggling with viral suppression. He's presently conducting a comparative effectiveness trial of COVID-19 testing modalities in Baltimore City. So the talk of his title is called Virus, Variants, and Very Challenging Times, the Impact of COVID on People with HIV. So welcome, Dr. Farley.
It's my pleasure. Thank you so much. Share my slides here and we'll get launched on our talk and journey here together. As already been stated, and as we all know, today is World AIDS Day, and commemorating this day is something that I find extremely important. I was just on a webinar before this talking about the impact of COVID-19 on patients with TB and HIV in South Africa. And from colleagues there who are dealing with Omicron and the new variant, they are sending well wishes to you, and just know that the world is in good hands when it comes to the wonderful, amazing scientists doing the work and determining how Omicron is really impacting patients with TB and HIV in South Africa. And I just always applaud them. I wanted to start out by giving them just a shout out, despite everything that's been going on with some ill-informed, in my opinion, travel bans. The work and the scientists are doing there in South Africa are just so critical to our understanding of what's happening. We'll talk a little bit more about Omicron in the presentation, really thinking deeply about the beginnings of the HIV pandemic and how that relates and the corollaries with SARS-CoV-2. We'll describe the epidemiology and really the presentation of SARS-CoV-2 in patients with HIV and whether or not patients with HIV are at greater risk of morbidity and mortality. And really think about how to look at vaccination programs and how to reach those most at risk among communities with patients at risk for HIV and living with HIV. So to kick us off, I really wanted to talk about comparing the two pandemics that now most of us have lived through. The HIV pandemic obviously is now 40 years strong. Today being World AIDS Day, I think it's important to recognize that, between 1981 and 1985, those 4, very painful years, we couldn't even diagnose the agent. We had no ability to really say someone was positive or not until they presented with key, cardinal signs of opportunistic infection. Not to mention, it took another 6 years plus. And when I say 1981, that's, again, the words recognize the epidemic in 1981 are really important there. We definitely have seen cases from dry blood spots and other samples that are available for testing that were positive as late as early as the 1950s into the 1960s. But it was really 1997 when we developed highly active antiretroviral therapy, that first cocktail of treatment, and are still waiting on an effective vaccine, although we have now had a handful of cases who have achieved a cure of their HIV infection. Again, it's only a handful, most of which through modalities that are inaccessible to the general population, like bone marrow transplant. Whereas when we turn our attention to SARS-CoV-2, the epidemic was recognized very quickly in December of 2019. The agent was isolated only a few days later with full genome sequencing and diagnostic primers and probes identified through PCR within, literally less than 30 days. Our first treatment became available for us, although we can argue its effectiveness, but the first treatment was available in May of 2020. We're really looking at greater efficacy of treatment modalities, but then we got a vaccine that is highly effective as of 2020. And so when we think about the timelines of these two pandemics, we have learned so much from the HIV pandemic that has influenced how we can respond from viral evolution, viral genomics, sequencing, that has really made our response to COVID-19 so much faster. And we think about how long it took us to even know the full genome of HIV. From the 1981 discovery, it was 2009 before we had a full genome sequencing. And it was because we had to do it in small bits and, spits and starts. We would get a little sequence completed of a certain gene area of the genome and then go back and refine it and keep refining it. And whole genome sequencing or next generation sequencing was not available at the time. Now, literally the time to a full sequence of the whole genome of SARS-CoV-2 was 8 days. Really remarkable progress. And so I like to point this out, particularly when I'm talking to a scientific audience, because we're really thinking about, well, how did folks get a target region so quickly for a vaccine? Well, really the timeline is presented to you perfectly on this slide, where you see the S region there, the spike protein region. We were able to map that, identify the target antibodies that could target that spike protein region. And it is that region where Omicron, for example, is showing such large diversity, so many mutations. I believe compared to Delta, which has about 4 mutations in the spike protein, Omicron has about 26 new. It maintains those 4 from Delta, but has 26 new mutations in the spike protein of about 30 mutations. And that's what's caused such alarm bells right now with Omicron in particular. But when we review this clinical spectrum of SARS-CoV-2, we've learned a lot in the last 2 years. Obviously, we still continue to see a fairly high burden of asymptomatic infection, a large number of people presenting with mild symptoms, and that is inclusive of the data coming out of South Africa with Omicron as well, the variant. The symptoms remain relatively mild. The people who go on to develop moderate to severe symptoms present with this list of symptoms that you can see before you. Lots of fatigue, lots of difficulty with breathing, shortness of breath, and a majority of those cases don't require hospitalization, don't go on to die. And that's what's fueled a lot of our conspiracy theories that are circulating on social media, because people across spectrums of political affiliation or life feel like, oh, I had it, it wasn't a big deal, we're blowing this out of proportion. But when we look at things related to who goes on to be hospitalized, we've seen the data clearly emerge that age is a huge factor. We've seen race and ethnicity play an important factor. We've seen comorbidity play an important factor. And when you look from an intersectional lens at that perspective, we know that when we layer in all of the various isms that occur in our society here in the United States, we have a primed pump for seeing great disparities among different populations. And so you can just see the data here of the majority of individuals being hospitalized, comorbidity was that driving factor. Well, when you add in all the social and structural barriers to accessing care, insurance, and many other things, race quickly becomes an issue in that those barriers are heightened for people of color. And then when we look across the spectrum, there are greater numbers of people of color living with HIV. So when we think about this, one stands to reason that this disease was a well-primed pump for impacting people of color with greater propensity than the white population. I like to show this picture because of those that get hospitalized, only again, another proportion of people go on to need mechanical ventilation. And there's a lot of discussion and details around, well, what influences health outcomes? Is it comorbidity? Is it immunosuppression? Is there some influence on race, ethnicity? And what you can see in the bottom picture from the Nature Medicine is just how much the immune response is driving, that cytokine storm is driving the clinical presentation and symptom burden you can see at the far left of this slide. And when an individual in the Nature Medicine paper went on to show that at baseline, cytokine levels, IL-6, IL-8, TNF-alpha, and IL-1, interleukin-1 beta, can predict mortality. And this is where this just really gets an interesting flair to it when we start to think about, well, what are the things that drive morbidity and mortality? are people that experience structural barriers to care, structural racism, trauma, have higher levels of cytokines at baseline, right? And so when we think about people with HIV and we think about all of the various intersecting identities that they hold, one theory, although not significantly proven, but you'll see some of this play out in some of the data that I'll share, is that when you've got a high level of ongoing circulating cytokines because of stress theory and many other factors, you may be at greater risk at baseline of having a negative outcome simply because of your lived experiences. And I think that's an important point to know. And then finally, as we think about this clinical spectrum, is persistence equal? Once people recover from COVID, do people recover the same? Do people living with HIV, for example, who have higher inflammatory conditions and responses have greater symptom burden? And is that symptom burden larger and longer and more intense than people without HIV? And that's an important ongoing question. But the data from the JAMA article back in 2020 proved to us that many symptoms were ongoing for long periods of time. And that's been subsequently updated in this analysis, which was from Nature Scientific Reports in 2021, showing us that there are more than 50 long-term effects of COVID-19 through this systematic review and meta-analysis. And what you can see is that the bigger the little circle is there, the more number of people have at least that symptom, 80% at least one symptom for long periods of time. And so that greater than 50% of people with long COVID experience fatigue. That orangey box is those in between 30 to 50% of people experience those symptoms, such as headache. And 15 to 30% experience that ongoing cough, chest pain, dyspnea. And we're talking about in terms of long COVID, for months on end, do people experience this? And importantly, you can see that they've overlaid on this slide the inflammatory markers that are being evaluated, and the D-dimer, the pro-BNP, the CRP, and so forth. And basically saying that, with abnormal chest X-ray, abnormal CT, and elevations in inflammatory markers, the higher those inflammatory markers are, the ones that are elevated, the more likely one is to go on to have long COVID. And given our patients and their experiences with HIV, and all the intersecting identities from a stress theory perspective, our patients with HIV are certainly potentially at greater risk of both experiencing long COVID symptoms and them lasting them for quite a long time. So I want to point out, with all of that as background, that people with HIV tend to be epidemiologically disadvantaged to COVID morbidity and mortality, while many may not be immunologically disadvantaged. And we'll unpack that a little bit further. Obviously, this data, is based on cases, hospitalization, and death from the CDC based on age. And we already talked about age being a big predictor of both hospitalization and death. And as you can see, is as you move across this chart from left to right, and go increased by decades of age, your likelihood of both hospitalization and death increases significantly. Now, important, when you overlay that data with people living with HIV in the United States, and this is data as of 2018, the average age of people living with HIV is 50. In my clinic, it's 51.5 years of age across our 3,500 patients living with HIV at our clinical setting. So we know that if we just flip back here, that those 50 years in age or older have a 25 times more likelihood of being hospitalized and a 440 times more likelihood of death. So age in our patients with HIV is a key consideration as we think about things that place them epidemiologically at greater risk. Also, we know that hospitalization and death is continued to be a relatively disparity head. It is showing in the Native American population 1.6 times greater cases, 3.5 times higher hospitalization, and 2.5 times higher deaths. You can see a slight increase for the Asian population, but in our African American population, 1.1 times higher cases, 2.8 hospitalizations, and 1.9 times death. Similar findings in our Hispanic population further to the right. Now, when we look at our HIV incidence and overlay kind of that data, we can still see this disparity play out in the new cases HIV from 2010 to 2019, clearly impacting people of color greater. You can see that the Hispanic Latino population has overtaken the Caucasian population in having greater numbers of new diagnoses every year. 87% of these diagnoses remain among men who have sex with men. And so when we think about this, we also have a sexual health and gender potential LGBTQ disparity happening. We have not seen, however, for COVID-19, an overlap outside of HIV, an LGBTQ related relationship in terms of morbidity and mortality. And it's probably because those studies have not really been completed. But when we look deeper into immunocompromised people and SARS-CoV-2 infection, we know that they're more likely to get ill from COVID-19. There's a higher risk for prolonged infection and viral shedding. And that's going to be a really important point when we come back to variants, that prolonged infection and viral shedding. The viral evolution during infection and retreatment has been seen in hospitalized patients. So patients who came in and needed hospitalization for long periods of time, remained PCR positive, and through sequencing, we identified new strains, new variants that emerged during a person's hospitalization. And depending on their level of immunocompromised status, there may be low antibody and neutralization titers against both variants, but in response to the vaccination. People, because of those three factors, just like with HIV, the higher the viral load, the greater the prolonged viral shedding is, the more likely you are to transmit the virus to household members and loved ones. So immunocompromised people who continue to test positive, again, that social isolation impact is there. They're needing to distance themselves from others, family, friends, loved ones, because there's greater potential for transmissibility both within household and the community. As well as immunocompromised people are more likely to have breakthrough infections. In one study, 44% of hospitalized breakthrough cases are immunocompromised people. In another study in Israel, 40% of hospitalized breakthrough cases were among people who are immunocompromised. Now, this slide is not only inclusive of HIV, it includes the broader definition of immunocompromised populations. And so when you're thinking about this particular slide, and I say those immunocompromised people, we're really talking about people with really low CD4 counts, less than 200. So, whoops, let me go back one slide. Well, we're going to move on now to just some treatment recommendations in general for COVID-19, and then specify how they are different for people with HIV. So here is the world view for the United States of how we treat COVID-19. On the left-hand side, and labeled figure 1, you will see for non-hospitalized adults. And you can see it's differentiated by whether or not an individual does not require hospitalization or supplemental oxygenation. So that first light blue box does not require hospitalization or supplemental oxygenation. And that's where those outpatient broadly neutralizing antibody regimens come into play. Again, those broadly neutralizing antibodies are often still in many communities difficult to find. They require certain referral patterns and may not be available and equally accessible in all communities. But that is if a patient tests positive and is symptomatic, but does not yet require hospitalization and or supplemental oxygenation, that's the regimen and the approach that we should go. Individuals in that category, and there's a couple of other blue boxes that you can see to the left there that I'm not going to focus on right now. I'm going to move us to the right-hand side, which is figure 2, which adds individuals that are hospitalized but not requiring supplemental oxygen. So those symptoms were bad enough that they needed to be monitored, but not yet with a pulse ox too low or a CT scan so poor that they required supplemental oxygenation. And right now at this point, they would most likely be receiving broadly neutralizing antibodies, but no additional dexamethasone or other glucocorticoid. Once oxygen therapy is required and needed, that's when you begin to add additional therapies, the remdesivir, the dexamethasone with remdesivir or dexamethasone alone. And it really, the guidelines committee in this recommendation were trying to give people options depending on what drugs they had available to them in the inpatient setting. And then you can move down, and if once you get mechanical ventilation or high flow device or non-invasive ventilation, the recommendations change again to dexamethasone with or without remdesivir. And then finally, in those patients who are required mechanical ventilation or ECMO, the recommendation is for dexamethasone. Again, with this, we've learned so much so quickly, and these regimens and are very effective if used in appropriate amounts of time, used with appropriate care, and you have access to them within your healthcare facility. Many of my patients on the left-hand side that I've diagnosed with COVID have really struggled with whether or not to seek out broadly neutralizing antibody therapy. They were like, well, my symptoms are kind of mild. I think I feel fine. My CD4 count is okay. Do you really think I need to do this? And so that's an individualized patient decision that I would just recommend that you at least have a conversation about the risk benefits of going that direction with your patients, because I know it's on a lot of my patients' minds who have been diagnosed with COVID over the last 2 years. When we take that snapshot and really focus down on what do those recommendations say for people with HIV, a couple things. It stresses the importance of vaccination and immunization and about the booster dosing of vaccine. It calls out the importance of advanced AIDS as a CD4 count under 200 and make sure that we paying close attention to patients who are severely immunocompromised, potentially even needing a 4th dose. In terms of monoclonal antibody as post-exposure prophylaxis, there is potential logistical considerations or supply chain issue, but if a patient has been exposed and they have a very low CD4 count, there is the potential in certain sites to refer for post-exposure prophylaxis. So they attended a wedding or a holiday event and someone around them tested positive. They've not yet tested positive, but there are certain treatment sites and locations across the country where people living with advanced HIV would qualify for a post-exposure prophylaxis broadly neutralizing antibody regimen. Diagnosis is exactly the same. Management strategies are exactly the same. There's really no difference. Early in the pandemic, we were doing lots of debate about whether or not HIV antiretroviral therapy would be effective. The current answer to that is unequivocally no, it is not. We also know that when starting treatment for COVID-19, clinicians need to pay special attention about drug-drug interactions, but in general, there is no reason to alter or change antiretroviral therapy for patients with this therapy. And you can even see down below in the last section on the management of HIV that an ARV regimen should not be switched or adjusted for the purposes of preventing or treating SARS-CoV-2 infection. So we don't want to proverbially rob Peter to pay Paul in compromising someone's antiretroviral regimen for their HIV treatment. So with the treatment kind of guidelines in front of us, let's look at what some of the observational studies on COVID-19 and HIV have told us about COVID disease outcomes. This was a study that my clinic participated in, and I have patients I contributed to this analysis looking at what are the clinical outcomes for patients and what are the predictors of those clinical outcomes. And what you can see here is to the right of your screen, a group of data on patients who were hospitalized, and in the white box below that, who had a severe outcome, including death, mechanical ventilation, and death. And what you can see in the adjusted analysis, the GEE analysis, is that age for patients with HIV is clearly a factor. CD4 count, the lower you go, below 500, CD4 count increases your risk by 47%, but below 200 increases your risk of hospitalization by 5.2-fold, 3.67-fold in the GEE estimation equation, the adjusted analysis. Patients with chronic kidney disease, chronic lung infection, and comorbidity. What you can see really importantly in that adjusted analysis, that having HIV with 3 or more comorbidities here in the United States really influence the likelihood of hospitalization. And that's not surprising. As someone who has moonlighted many, many years in the emergency department here at Hopkins, someone coming in with HIV, COVID, and multiple comorbidities is going to get you on the short list for admission, most likely anyway. So I think clinicians out of a burden of caution would be more likely to admit patients. But more importantly, looking down below in terms of severe outcome, I think you can see clearly in the GEE analysis that age had a slight influence on severe outcome, increasing the odds by about 4%. CD4 count, again, now it was that the CD4 count below 200. We lost the statistical significance for those below 500, and really those with severe immunocompromised status of below 200 showed increased odds of severe outcome. Hypertension, chronic lung disease, and comorbidity all were significant in this group. But when you looked at what predicted the most severe outcome, it was living with HIV and associated comorbidity of 3 or more. Now, importantly, as I said, we have an aging HIV community. And so when I say they are more epidemiologically advantaged than being immunologically advantaged, it's because of data like this, where we see with increasing comorbidity that comes with the aging with HIV, that is a big driver across multiple studies. In the TriNex study, and this was about 50,000 patients with COVID-19, 404 of them were people living with HIV. The crude analysis at the very bottom of the mortality was higher in people with HIV. However, once propensity matched analysis was completed, it revealed no differences in outcome between people with HIV versus not, showing that the higher mortality in the TriNex study was driven by higher burden of comorbidity and not the HIV status. So I think, this is, again, I mentioned at the beginning of the talk that there's mixed data, mixed signals here, whether or not it is just the comorbidity that comes with aging and HIV, or if it's HIV itself. I tend to come back on, after I show you this next slide, I'll give you the answer. But this was a large UK study using the ISRAC, World Health Organization clinical characterization for COVID-19. It was a study across multiple 207 centers in the United Kingdom. And they had 47,000 patients, 122 of those were living with HIV. And 91% of them were on ART. And the bottom line for this, I think, is on the next slide, but I think I summarized it for you here to the left. It was that among hospitalized patients with HIV who were less than 60 years of age, they had greater than a 2-fold risk of 28-day mortality after adjusting for sex, ethnicity, 10 comorbidities, and hypoxia presentation at baseline. So in this analysis, they said basically, sure, comorbidity impacted those over 60, but for those less than the age of 60, it was really the HIV that was driving that negative outcome. And so really importantly here, this is yet another nuanced piece of data. So the way I come down on this and this data is that I clearly think HIV is impacting clinical outcomes for both hospitalization and death. It does appear that it is more pronounced, as we would expect, among patients with severe immunocompromised status, less than 200 CD4 counts. But because of the nuanced relationship between HIV, aging, and associated comorbidity, I think our patients with HIV are clearly epidemiologically at greater risk of both hospitalization and death. And therefore, we must stress the importance of COVID-19 vaccination and other prevention modalities. Now, amongst those in this table here, this table 5 with HIV, they did a sub-analysis and they looked at the 30 people who died and the 92 people with HIV who were alive at the end of the 28-day mortality evaluation. And in this particular study, I just wanted to point out, if you look at the statistical differences among those who died with HIV, it was statistically significant difference, although low sample numbers in diabetes compared to patients who were alive at the end of the study. So again, even amongst the analysis of death here, comorbidity playing a key role in that finding. So what has now, we talked about HIV and its impact on COVID-19 outcomes. Let's talk about the impact of COVID-19 on HIV treatment and prevention. Now, this cartoon or schematic that I designed here is just really centering COVID-19 and its impact across the HIV treatment program. I mean, we've seen data on viral suppression impacts. We've seen data on mental health, social isolation, and stigma. We've seen increased substance abuse and overdose. Our syringe support programs and their naloxone administration here in Baltimore has seen record high use throughout the pandemic. We've seen increases in vulnerability that place people both at risk for HIV as well as COVID-19, such as unstable housing, economic instability, increased poverty. And then ultimately, the patients in our HIV programs and in our HIV prevention programs have had a disruption of their patient-centered medical home, requiring virtual models of care as well as virtual supportive services. And when we think about patients on long-term regimens for HIV, we know that many factors impact adherence over the life of an individual. And some great research has been done that I've cited here, including some great nurse research by Bill Holzheimer and colleagues on factors impacting adherence. And the ones that I turned red here for you are the ones that there's clear evidence for that individuals as a result of COVID-19 have been impacted living with HIV. So I think it's been extremely important to help really think about what the disruption to the patient-centered medical home has been. And that's what this slide is all about. And I offer the schematic to the right, which is getting old now. It's about 6 years old. But the eHealth enhanced chronic care model that was designed to be a virtual kind of model of care for chronic illness management and ways in which we could really think about the ways we structure our practices to be more e-health friendly. And I pose these questions that you can think about and maybe we can discuss in the question and answer, but really how have our HIV telehealth programs or our HIV care programs been doing under telehealth? Some of my patients on my PrEP panel love it. They said, Jason, I don't want to ever come back to see you again. I can do everything virtually. You can send me my STI kit at home, my HIV testing, and I can see you on camera. That's great. My HIV patients that I've been seeing for decades now, they're really like, hey, I miss seeing you. I'd really love to touch base, going to the LabCorp to get my labs and then seeing you on camera is just not the same. And so they miss that sense of social connection. So, but we do need to think about how we're going to maintain differentiated models of treatment. Can we do longer refills? Can we maintain text messaging and reminders and mailed pill boxes that have already been filled by our pharmacists or nurses? And can we use external lab providers ongoing and help democratize and liberate some patients from the chains of our clinic structure? And I'm hopeful that we can actually do some of that moving forward to make care much more convenient. I would argue that the virtual patient-centered medical home will be the new normal after COVID-19, and we need to figure out how we're going to integrate ourselves into this new virtual space for health decision-making. But it's not a panacea. We've seen data that came out of COVID, the HIV clinics in San Francisco showing that the odds of being non-suppressed were 31% higher in April of 2020 versus pre-COVID pandemics. They were threefold higher in the homeless, and 54% of visits that were supposed to be scheduled as telemedicine had to be turned into telephone visits. So again, not everyone has access to there's a huge digital divide, and we have to pay close attention to that. And they felt that retention in care via telemedicine for their populations in San Francisco were not sufficient to keep viral suppression rates stable. They saw a loss of viral suppression is deleterious to the individual and hinders treatment as prevention. And that data just seems to be replicated. We're now doing a systematic review and hopefully meta-analysis on this exact impact globally among HIV programs for people living with HIV impacted by COVID. And the same was true. This is data from Boston in the PrEP Fenway program, PrEP program, showing that the number of HIV tests basically plummeted. The number of new PrEP initiations for prevention also declined. And the number of PrEP lapses in that blue bar there significantly increased during early part of the pandemic. So we now move our thinking to what's happening with variants in people with HIV and what do we know. But first, to orient us onto the variant alphabet, this was a great schematic put out by Al Jazeera just yesterday. For those that have the bright orange, those are our variants of concern. You can see alpha, beta, gamma, delta, and now Omicron. And those in the kind of lighter orange are all the variants of interest that are just being followed. Remember, there's a lot of additional variants that haven't made this list yet, but as they come up and are identified in clinical populations, they are evaluated through sequencing data, just like we were talking about before. And why are variants so important? Well, we know that, for example, the data that has emerged on Delta means that the R naught, or the likelihood of infecting other people compared to the Alpha strain, moves from approximately 2 to approximately 5 to 6. So for every person that has Delta, they're more likely, because of higher viral loads, to transmit to 5 to 6 other people. With Omicron, we are expecting similar changes in transmissibility. So far, the signals with Omicron are that pathogenicity is about the same as Delta. Mild symptom presentation thus far, but again, it's early days and too early to tell. But what does having HIV, and in particular immunocompromised status and uncontrolled HIV, do to propagate COVID variants? And there are a variety of now reports that are emerging. And this is an example of a woman who's 61 years old living with HIV in California, who is not on antiretroviral therapy. And if you look to the right here at her timeline, at day 0, she had symptom onset and test PCR positive 10 days after her symptom onset. She was lost to care between day 10 and day 30, but was admitted to the hospital on day 30 with replication positive, PCR positive COVID-19. At that time, her CD4 count was 13 and her viral load was 261,000 copies. She was started on ART at day 38 in the hospital and remained PCR positive almost until day 93, when she finally tested negative. Her viral load did decline and was undetectable before the end of the 90-day period. But what they found with this particular, because of the prolonged infection, it gave the virus the opportunity to have a mutation playground. Basically, she became an incubator for variant development. And we think this is likely similar kinds of scenarios and why places like South Africa are finding variants so much quicker. Not only is their sequencing data top notch, again, I just have to emphasize that, but they have a lot more of patients without viral suppression. In the United States, for example, we're sitting around in the general population, 60% viral suppression. In Ryan White clinics, 85% plus viral suppression. So our total proportion of people with viral suppression is much greater than for example, in South Africa. And then our numbers of patients who are AIDS defined are much lower. So in a patient who has CD4 count that's less than 200, they are much more likely to have prolonged viral shedding, much more likely to test PCR positive over a potentially longer period of time, and therefore with greater viral replication. This particular virus mutates quite easily. So what do we know about COVID-19 in people with at risk or living with HIV? And I wanted to say, just to give a huge shout out to Linda D. And she is a lawyer by training and the founder of AIDS Action Baltimore. You can read the NBC article about people being excluded who are living with HIV from COVID-19 vaccine trials. And she went to bat, got a huge petition signed, focused initially on Moderna and Pfizer, which forced Pfizer and Moderna to open the vaccine to people with HIV. Moderna initially enrolled of its first 30,000 patients, 176 people with HIV. Pfizer was 196, and then J&J was 1,218, and that principally had to do more with where J&J initially did some of its original clinical trial. this question we get a lot from our patients living with HIV. It's, I'm fully vaxxed. Do I need a booster shot? Should I sign up for that? And, you know, people with HIV, certainly, I am recommending for all of my patients to get booster dosing, booster shots. I've got patients with HIV who are also organ transplant recipients. And of course, we had been planning to boost them for quite, even before boosters were recommended. We've been doing that in our clinic just because we see such poor titers post second dose response in our transplant patients. But I show you this because although HIV is not specifically called out in it, you can clearly see that organ transplantation and patients on immunosuppressive therapy and patients with cancer are definitely see a lower % antibody response across these. We also see this with patients with low CD4 counts as well. So I think there has been limited data, honestly, in patients with HIV on the safety and effectiveness of the vaccine. We need more data. And I think we've got lots of observational data now, because certainly HIV clinics across the country have vaccinated their patients and recommended the vaccine. But now it's the head scratching period where patients are asking us lots of questions about booster shots. So here's what the FDA has recommended about Pfizer vaccine recipients. 65 years of age and older, 18 years of age who live in long-term care, anyone 18 years of age who have certain high-risk medical conditions, and patients with HIV fall into that setting, and then those who live or work in high-risk settings. So yes, patients with HIV are recommended to receive a Pfizer vaccine booster. They qualify. Moderna, same thing, high risk of severe COVID-19 complications. I hope I've convinced you that patients with HIV, particularly severely immunocompromised patients, are at high risk of severe COVID-19 complications. So I again would say patients with HIV would require a COVID-19 booster. For J&J, given that everyone received a single dose of J&J, the use of a single booster dose of the J&J vaccine may be administered at least 2 months after completion of the primary dose, but they can also consider receiving a different vaccine or mixing a vaccine. And the use of these vaccinations are safe and effective. And there's data now showing that if you got 2 of Pfizer and you wanted to take a 3rd now of Moderna, you actually get pretty high neutralizing antibody responses above and beyond what you would get if you received a 3rd Pfizer dose. So mixing vaccine boosters is something that I've seen patients ask questions about. And right now it appears the data is strong that that is a safe and effective way if they wish to do so. So some examples of how we would apply this in the real world, I think, are important. So you've got a Janssen COVID-19 vaccine recipient who's 18 years of age or older. They may receive a single booster dose of Janssen vaccine. They can receive a Moderna COVID-19 vaccine half dose or a Pfizer BioNTech COVID-19 vaccine at least 2 months after receiving their primary dose. If they received a Moderna vaccine or a Pfizer vaccine, they fall into one of the authorized categories for boosters, but now we're saying boost everyone, right? The booster dose could be a half dose Moderna. It could be the full dose of Janssen, a full dose of Pfizer, or the Janssen vaccine. And that's any of those are options at least 6 months after completing their primary vaccination series. And to make things more complicated, there is one more point to consider. So the CDC recommends giving an additional dose of mRNA COVID-19 vaccine to people who are at high risk of having suboptimal immune responses to the 2-dose series. Now, that is not a booster. That is a 3-shot regimen for people who likely to have a suboptimal immune response. And for people with HIV, that would be individuals not virally suppressed with a CD4 count below 200. And they would get that 28 days after they received their 2nd dose. And that would be dose 3. Now, importantly, that needs to be followed up in those individuals with a booster 6 months later. And that would be really important to make sure that patients with HIV with severe immunocompromised status, whether or not had a transplant or not, but have a CD4 count below 200, that potentially 4 doses are recommended based on whether or not they've had an optimal response to the vaccine in the first 3. I want to leave us with the thought of what we've been doing here in Baltimore to improve vaccinations amongst our most at-risk communities. You know, when we started this process and we started giving COVID vaccines in the communities, you know, people at risk with HIV, our substance using community, everyone said, oh, you will never get people to come back for a second dose. You must only offer them J&J. That you must do that because you can't get people potentially homeless, substance using, at risk for HIV because of sex work and other conditions. You might not get them to come back for their second dose. Well, we proved that to be rubbish. First, I refused to give them only one dose option, and I was very happy that we made that choice because all the blood clot issues came out right about that same time with J&J vaccine. 40% of our vaccine recipients this is our first clinic day. 60 people got vaccinated that first day. 40% of them chose the J&J single dose. They did not want to have to come back. They understood the recommendations. Remember, the blood clot issue with J&J was women over the age of 50. Most of our patients were men. So that didn't influence their decision-making at all. But 60% chose the 2-dose regimen. So when they were given choice, an agency in choosing, they chose 2 doses, the majority of people, and 92% of them we were able to get back in for that second dose. So I would push back to anyone who's saying to you that you can't get really high risk, vulnerable populations, you know, with marginally health status and the like to come back and get vaccinated, because you can, and they will. We offered things like Uber and Lyft and food options, and partnered with our syringe support program so that they were doing some shoe leather, you know, epi. Hey, just wanted to let you know we're returning it to this site at this date and this time, as people were getting their syringes exchanged and those kind of things, and really that partnership was highly effective in getting people that 92% return for that second dose. We've done 5 or 6 of these now and are planning our booster clinics at this time to go back out into the community, making sure we can offer. We also co-located HIV and STI testing at the same time with these vaccination clinics in order to be able to facilitate full service rendering. We offered wound care, a hot meal as well, just so that we can make sure that we were being, you know, we were attracting people to come to the site to figure out what was going on, and then we could have the appropriate health education to get people vaccinated. So with that, I will turn it over to my moderators and see if there might be any questions that I can address about the presentation.
All right, thanks, Dr. Farley. I encourage the audience to submit their questions to the Q&A tab on this platform. So waiting to see if anyone submits anything.
Sorry for going a little over on time there.
Right,
I wasn't able to see the countdown.
It's all great stuff, though. Yeah. I saw Inuma has her hand raised, but if you can submit your question to Q&A, that'd be great. It's just a comment simply saying that this was very informative. Thank you.
Great. I'd be interested to hear if anyone has any experiences they'd like to share related to their HIV clinics or practices, or how their patients might have been impacted living with HIV by COVID-19 as well.
Oh, wow.
Silence.
Silence, yeah.
Well, hopefully I have answered any burning questions you had about the topic. Looks like we've got one.
All right, so there's a comment stated here. Comment about the regions with high rates of HIV-related immune suppression, including COVID evolution was interesting.
Yeah, there are a couple of case reports now, case series where, and it's not just HIV, and I don't want to say it's only people living with HIV. We've got case reports of people in my HIV clinic and in my transplant patient who became COVID-19 positive. He tested PCR positive for about 90 days early in the pandemic. And we had serial repeated tests for him, and subsequently because of his immunosuppressive agents, developed no actual antibody post-COVID-19 infection. He lost some smell and taste for about 1 or 2 days, but those were his only symptoms, never progressed to any kind of severe infection. And he is an individual that we wound up giving 4 doses to, and in that 4th dose actually withheld his transplant anti-rejection medicines for a couple of days in collaboration with transplant to see if we could help boost his levels of broadly neutralizing antibody post-vaccine for that 4th dose. So
there was a follow-up comment or question. It was like, what are your thoughts about the global health implications of this what you're observing and studying right now?
Yeah, I think, from a global health perspective, it pains me to say that global health is talked about in a really good game until the rubber hits the road, right? The vaccine exceptionalism, the vaccine hoarding, the buying up by rich countries of vaccine, not effectively administering them. I think programs like PEPFAR should pivot and allow, their nurses and physicians who they support to become COVID, vaccine champions and providing COVID-19 vaccination. Now, with that said, I understand that would strain the health system for the HIV care that they're receiving. But I want to also say that it is already severely strained by COVID-19, and many, many people in TB and HIV around the world have been pulled already to do COVID work. They're just, PEPFAR is not covering those costs. And I think we could expand our workforce who's able to provide vaccination if the funder and the funding mechanisms like Global Fund and PEPFAR were more engaged and willing to allow the HIV workforce to participate in a greater way.
Okay, great. So someone I was asking for clarity as to which clinic were you doing your work? I guess whether or not if that was specific to Baltimore or your work in South Africa.
Sure. So my clinical practice as a nurse practitioner is in the Bartlett specialty practice at Johns Hopkins. I've been there about 20 years now, practicing as a primary care HIV nurse practitioner. I center some of my research there, but most of my research work is in South Africa. Our COVID work has been in the general population and general community, not specific to people living with HIV, although we've enrolled several patients, some of mine as well, in that work.
Okay. And then there was a question or comment saying, with the slide containing all the statistics, percentages of post-COVID symptoms earlier in your presentation, was there any percentages for loss of taste?
Yeah, dysgeusia was on there. Let me find it and see if I can quote that for you. Let's see. Loss of taste is in 23% of people experiencing long COVID. That is the symptom they're reporting.
Okay, great. And one final question, as I know we're running out of time. First comment was excellent talk. Dr. Farley, could you comment on the impact of COVID on patients with TB, HIV co-infections?
Yeah, that's the webinar I just came from, hearing from one of my colleagues in South Africa. Clearly, globally, TB has been markedly impacted by COVID. Every patient who comes in with a cough in South Africa gets a COVID test and then sent home. And if they continue to cough and it was negative, then they come back for a TB test. I've had nurses tell me that they've really struggled with getting people to think about TB in the middle of the COVID-19 pandemic. When I was in South Africa last in August, I was speaking to a nurse who's running a clinic of about 10,000 people. And she said daily, she goes in through the clinic reminding people to think TB when patients come in with COVID symptoms. The National Health Laboratory Service of South Africa has reported, for example, approximately 25% decline in the number just of TB tests in general. And then a number of patients presenting with TB and initiating therapy. For example, in the one hospital, just as an anecdote, the one hospital we work in normally would initiate about 400 patients with drug-resistant or antimicrobial resistant forms of TB. About 70% of them would be HIV co-infected. And in August, they had initiated 47 for the year, meaning that GeneXpert has been pulled and being used for COVID testing. People aren't thinking TB, people aren't diagnosing TB, and that's ultimately going to drive morbidity and mortality beyond the secondary wave of complications that come after COVID.
Okay. Well, thank you, Dr. Farley. We have gone beyond our sort of allocated time. We want to appreciate your contributions to this conversation, presentation to the UIC community. We do want to tell the audience that the UIC Colloquium, Global Health Colloquium, the next session is going to be February 2nd at noon. So stay tuned for an announcement on who's going to be featured and what the topic will be. This session today was actually recorded, so that would also be distributed as well. So thank you, everyone, and have a great day.
Thanks all for the wonderful questions.